Assalamu alaikum wa rahmatullahi wa barakatuh. We are going to introduce the main point in the rheumatoid hand examination. Rheumatoid hand examination is classified into 4 stages. Stage 1, that's the inspection. Stage 2 is the palpation. Stage 3 is the movement assessment. And the last stage is the neurological assessment. So we'll start by the first stage of the inspection. First, when you start to inspect the patient, we start distally and go proximally. This is to be well organized, not to miss any point of the examination. First, we are going to examine the nails. Nail is a very important organ for examination into rheumatological diseases. So nails, the abnormalities seen into the nails. Number 1 is the presence of what's so-called nail bitting. Nail bitting, presence of fine dots onto the nail. And this is characteristic of what's so-called psoriasis. Psoriasis, as we know, is one of the causes of the arthropathy, psoriatic arthropathy. So presence of nail bitting is a diagnostic point for presence of psoriatic arthropathy. Okay, very important. Number 2, presence of what's so-called is a splinter hemorrhage. Into the nails, you see there is a splinter hemorrhage. There is the red spot into the nail, is so-called splinter hemorrhage, and characteristic for infective endocarditis. As we know that infective endocarditis may present with an arthritis and arthropathy. Number 3, presence of the onycholysis. Presence of onycholysis. There is lysis of the nail. We see that the nails is getting up from the side. The nails are going up, and there is abnormality into the nails, what's so-called onycholysis. And this is characteristic for psoriasis. Characteristic for psoriasis. Nail involvement is very important differentiating point between the rheumatoid hand and between the psoriatic arthropathy. Psoriatic arthropathy can cause the same presentation of rheumatoid arthritis by deformities and by the hand involvement. Differentiating point is the nail involvement. Differentiate psoriatic involvement from rheumatoid. Rheumatoid doesn't involve the nails. Okay. The second point is very important. By inspection, should expose the patient looking for evidence of any muscle wasting. Look for evidence of any muscle wasting. Okay. So we have the stages for muscle wasting. Number 1, muscle wasting. You see that a flat area into the hand. Stage 1, you see one part. There is a muscle bulk, prominent muscle. This is normal muscle, and there is a flat area. The flat area are suggestive that there is a muscle wasting in that area. There's a muscle wasting, number 1. Number 2, what we see here, there is, other than the flatness, there is a reduction into the site of the muscles. The patient had a flatness. The second stage, that patient a deep flat hand. So that the breast area down. See, there's a flat, number 1. Number 2, there is excessive muscle wasting, leading to that there is a depressed area. You see this area is depressed down. The third stage, what we see called is a groove sign. Groove sign. And groove sign as a grooving, al-khadid. This is grooving. You see that there is a wasting of the interosseous muscle. Significant interosseal muscle wasting, leading to what's so-called grooving. You see there is a deep groove in between the phalanges, the proximal phalanges, this area called the proximal phalanges. There is a complete wasting, and you see there is a groove sign, a grooving of the area, which suggests the third stage of the muscle wasting. The third point, looking for evidence of any swelling. The swelling, we have 2 parts of the swelling. Number 1, we have a bony swelling, and there is a soft tissue swelling. We have 2 things. We have soft tissue swelling, we have a bony swelling. Bony swelling, this is due to the what's so-called osteophyte formation. Osteophyte formation. Osteophyte formation, this is a bony swelling. Okay, osteophyte, this is a bony swelling. And the osteophyte swelling, the swelling become to the side of the joint. You see the osteophyte not on the top of the joint. See the osteophyte are coming from the side of the joint. Osteophyte suggests that the patient has a degenerative disease. The patient has degenerative disease like an osteoarthritis, different form of osteoarthritis. Primary osteoarthropathy or due to the secondary post-traumatic osteoarthritis. Number 2, swelling around the joint. This is maybe due to the collection of the fluid, the synovial fluid collection. Synovial fluid collection. This is a soft tissue swelling. This is within the joint. You see around the joint here there is a swelling. This suggests that the patient have a synovitis and synovial proliferation, and there is synovial fluid accumulation, and this is around the joint. Osteophyte are coming from the side of the joint. Soft tissue swelling coming over the joint. Very clear? The other point into the site of the swelling, we have a swelling other than the joint area, we have a swelling around the dorsum of the hand. You see a swelling around the dorsum of the hand. And this is suggestive of the issue of the synovial cyst formation. There is a synovial cyst formation, okay? Synovial cyst formation appear commonly over the issue, over the dorsum of the hand, appearing over the dorsum of the hand. So we have a bony swelling, this comes from the side. We have an over the joint, there is issue, synovial fluid collection will indicate that the patient has some form of a joint effusion. The other point, there's a synovial cyst formation, accumulation of the synovial fluid and lead to accumulation, obstruction of the area and become prominent cystic swelling around the dorsum of the hand. A very important point is the swelling. Here we're missing one point. After the swelling, we have the scars. We didn't mention the scars. Very important to look for evidence of scars, okay? We have different scars. Scar, common site of the scar over the dorsum of the hand. So you're looking for a scar over the dorsum of the hand, which suggests a synovial cyst removal. For the patient with a rheumatoid hand, they have a transverse scar, which suggestive that of synovial cyst removal. Very important. The other point in the scar, you see the scars over the flexor reticulum scar. This is the area of carpal tunnel surgery. Carpal tunnel surgery, release of the median nerve. You see the scar over the palmar aspect of the flexor reticulum in this area. There is another scar here, another scar of the dorsum of the hands. Okay, very important point is the scars. Okay, after the scars, we are looking for evidence of what so-called skin rash. We have a very important skin rash with characteristic point. Usually the skin rash are coming over the knuckles, this area called knuckles. The prominent bony area, this is called knuckles. Presence of skin rash over the knuckles. This is depend on the color of the scar. We have here, if you have a whitish black, like a chalk-like, whitish in color over the knuckle, this suggests that the patient has a psoriatic involvement. There's a psoriasis and there's psoriatic involvement, and the diagnosis is psoriatic arthropathy. Okay, very important differentiating point. We said that the nail and the presence of psoriatic patches over the knuckle, or this area called knuckle. Presence of psoriatic patches over the knuckle suggests the patient has psoriatic arthropathy. The second skin rash, here we have found most commonly is a violaceous color over the knuckles. Violaceous color over the knuckles, that was so-called Gutron sign. And this is diagnostic of dermatomyositis. Look into the hand of the patient, found a violaceous color over the knuckle. Violaceous color is not a red, it's a violaceous color. This suggests that the patient has a characteristic for dermatomyositis, okay? The other point we're looking for is looking for evidence of deformities. So deformities, rheumatoid hand, to differentiate deformity, go from the proximal and go distal. Go from proximal and go distally. Approximately, the first thing here in deformity, number one, we found that this patient has what's so-called piano or K pathology. What's piano or K deformity? Piano or K, you see there is a styloid. This is a carboradial joint. This carboradial joint. This is a part wrist joint. We have two joints. We have a carboradial, we have a carbo-ulnar. Carboradial, there is a prominent styloid process, okay? This one becomes up so prominent due to the joint subluxation. There is a prominence of the issue of styloid process. You find that it's going up, so clear. It's an up. This is due to the subluxation of the carboradial joint. Subluxation of the carboradial joint, and this is common in piano players with so-called piano-ish or K. This does occur with the patient who have rheumatoid arthritis with excessive hand-ish working, okay? You have a piano or K. Then you go, secondly, to the what's so-called here is a metacarpophalangeal joint. MCBs, metacarpophalangeal joint. The most common deformity at this stage, there is an ulnar deviation. There's an ulnar deviation toward the ulnar. You go ulnar deviation of the metacarpophalangeal joint. So ulnar deviation, not of the wrist. This is a common mistake in the exams. Ulnar deviation, not of the wrist. Wrist, there is a radial deviation going like this wrist. But here there is an ulnar deviation of the metacarpophalangeal joint, or there is an ulnar deviation of the digits. If they ask you, you said that there is an ulnar deviation of the metacarpophalangeal joint, or there is an ulnar deviation of the digits. A second deformity at the MCBs, metacarpophalangeal joint, what's so-called the flexion deformity, fixed deflection deformity. Normally, hands in this position, this is the wrist position. In patient with deformity, at this stage, which you have a flexion deformity. You see his hand like this. He's unable to do it like this. So there's there's what's called fixed flexion deformity. So at the MCB joint, there's a fixed flexion deformity. Okay, clear? This is the deformity which does happen at the MCB. Then you go to the deformities which happen at the proximal interphalangeal joint, what's called PIP, or distal interphalangeal joint here, DIP, distal interphalangeal joint. So we have two pathology here, and we have two pathology. First pathology is swan neck deformity. Swan neck deformity, or عنق البطة, swan neck deformity. There's an hyperextension at the proximal interphalangeal joint. There is hyperextension here, hyperextension, and there's a flexion at the distal. So hyperextension here, and there is flexion at the distal interphalangeal joint. This is called swan neck deformity, going like this. There's hyperextension at the proximal, and there is flexion at the distal. The second deformity, what's so called is a boutonniere deformity, or buttonhole. Boutonniere deformity. Boutonniere, this is by French language, boutonniere deformity, English buttonhole deformity. So what we see here, there is a flexion, there is a flexion at the BIB, at the proximal interphalangeal joint, and there is hyperextension at the distal. Flexion here, and there is distal. This is what's called button. And what the patient, why it's called button? This is the button. This is the button, and this is the buttonhole. This is the buttonhole, and this is the button. So the patient unable to close his button, okay? Then this is need to flex the distal interphalangeal joint. To close this one, you need to flex the distal. The patient has hyperextension here, is unable to fix the button into the buttonhole. This is what's called the buttonhole deformity. This is a very important deformity, okay? I mean, under deviations, piano or K, fixed flexion deformity, swan neck deformity, and buttonhole deformity. The other deformity, what we are seeing, what's called this is a rupture of the extensor tendon. Patient with rheumatoid hand, with excessive use of the hand, this is the most commonly a ring finger, what they call this finger. This is a rupture of the extensor, the excessive use. The excessive use of the hand by writing, by the keys. So the excessive use of this tendon is leading to rupture of the tendon, and the patient will have a drop of the index finger. Index finger will drop down. You see the patient hand like this. This one is dropped down. This is due to the rupture of the extensor tendon. Rupture of the extensor tendon. This is another deformity. This is the most common deformities in the rheumatoid hands. The other point, you need to inspect into the palm. The hand is not only the dorsum. You need to examine the palm. Most of the students, they forget to examine the palms of the hand. You need to examine the palm of the hand. If you look into the palm of the hand, we are going the same sequence, okay? Number one, you're looking for the muscle wasting. Muscle wasting. The commonest wasting into the palm, or wasting of the thinner and hypothinner muscles. Thinner and the hypothinner muscle wasting. You see flat muscle here. See the hand, you see here, there is the main bulk of the muscle. And the patient with wasting, you see this one is flat. And this one is more flat. So flatness or depressed area stages of the thinner and hypothinner, as suggesting the patient has a carpal tunnel syndrome. Suggests that our patient has a carpal tunnel syndrome. Number two, into the hands. Looking for evidence of what? You're looking, go to the digital bulbs. This is a digital bulb. The terminal phalanges, there is a digital bulb here. Look for evidence of skin rash. You see here, at the skin rash here, you see a red spots over these terminal phalanges. There is a red spot of the terminal phalanges, and this suggests of what's so-called rheumatoid vasculitis. Rheumatoid arthritis rarely causing vasculitis. Once causing vasculitis is very severe, it's painful, and it is localized on the terminal phalanges. You found the vasculitic, the red spot does not blench or pressure. You pressure upon it, it doesn't blench on pressure, indicate that there is a vasculitic lesion. Site on the terminal phalanges. Number three is pain. Pain, terminal phalanges, okay, and don't blench on pressure. This suggests that the patient has a rheumatoid vasculitis. The other important point, into the hand, you look for evidence of palmar erythema. Palmar erythema. There is redness in the thinner and hypothinner. It's called palmar erythema. There is redness in this area. Palmar erythema, there is a multiple causes of palmar erythema, but the rheumatoid diseases, palmar erythema suggests that the patient has an active disease. Your patient coming with palmar erythema suggests that his disease is an active disease. Palmar erythema is due to the release of the inflammatory mediator, indicate an active inflammatory stage. There is a release of interleukin 1, 2, 6, 8, tumor necrosis factor. Release of inflammatory mediators are vasodilator, leading to the redness of the issue of the thinner and hypothalamic muscle, what's so called is a palmar erythema. What's so called is palmar erythema. This is by the inspection of the palm of the hands. Okay. Then second stage, we are coming to the palpation. Palpation very important. What we are going to palpate for? First thing, you should palpate for the temperature. Second, for the tenderness. Temperature should be assessed by the using of dorsum of the hand. Most of the students, they are assessing the temperature by putting the palm of the hand, and this is wrong, okay? You will miss a lot of marks into the exam. So you should apply it, the dorsum of the hand. Dorsum of the hand should be applied to different joint. Apply your dorsum of the hand over the wrist joint, then apply to the MCB joint, then apply to the proximal and distal, looking for if there is evidence of any hotness. If there is any hotness to the base, suggest that may be inflamed joint. Temperature, there is hotness, indicate inflammation. Hotness indicate there is inflammation, okay? Excessive hotness indicate inflammation. Number two, should examine for the tenderness. Tenderness is very important. How to assess tenderness in the rheumatoid hand? Assessment of tenderness in the rheumatoid hand, you should use the index and the thumb finger. You have 4 fingers to be, only this finger used for tenderness. The index and the thumb finger are used to assess the tenderness into each joint. So start by the joint. نحن joint عندنا two parts of the joint. عندنا anterior, posterior part of the joint, and there is a lateral joint space. So joint here is open from all sides. There's an anterior, posterior joint space, and there is a lateral joint space. So apply your index and finger from up and down, and press firmly and look into the eyes of the patient. Look into the eyes of the patient, don't look into the eyes of the examiner, and look if the patient has a tender. If you press here, the patient there is a tenderness. So anterior, posterior, then press from lateral side, index and thumb, a press from two sides here, and you look into the face of the patient for evidence of any tenderness. Okay, apply joint by joint. Apply it here, apply it here, apply it here, joint by joint, proximal and distal. Okay, anterior, posterior, and lateral. MCBs, just an anterior and posterior. Apply anterior and posterior, press between the index and the thumb. In the patient with the wrist joint, tenderness by pressing to the carboradial joint and press to the carbo-ulnar joint. So wrist have two joints. Don't miss, wrist joint is not one joint. There are two joints. Carboradial, and we have a carbo-ulnar. Press anterior posteriorly, then press laterally. Apply the thumb for this side, apply the index and press and look into the face. Every part of tenderness should look into the face of the patient. Very important point into the exam, especially for postgraduate. Okay, it's very important to assess for the presence of the tenderness. Okay. Third point, what's so-called fluctuation. Fluctuation, rheumatology, they are used for detect the presence of fluid. While you are doing tenderness here, apply anterior posterior. If there is a fluid, you feel there is a fluctuation. There is a fluid in the synovial, there's some fluid. If you press anterior and posterior, like tenderness, من فوق اللوطة, you feel that there is something is moving beneath your hands, beneath your finger. There is some fluid moving, what's so-called fluctuation. Apply it anterior, posterior, and apply it laterally. Apply it here anterior and posterior. Apply the carboradial. Look for any increase into the fluctuation. Fluctuation indicates that there is the increased level collection within the synovium, which suggests that the patient have an inflammatory state is going on. Very clear, this is the fluctuation. This is how you are going to do a palpation, okay? The third part of the examination, very important part, and this is most of the students, they are missing a lot of marks in the movement. Examination, we have two parts of examination, an active examination and then passive. Active, that the patient using his own hand, he's doing the power by himself. Passive, the examiner or the candidate who is assessing the power of the patient, okay? First thing, we're looking for the active. The active part, we are going to assess all the muscle. The muscle of the hand, نحن عندنا muscle عندنا trochleus muscle. Should be aware that the examiner will ask you about the name. Most of the students don't know name of the muscle. The proximal muscle is called trochleus muscle. This is the osseous. So this is the osseous, and this is trochleus muscle. And the small muscle in the finger is called lumbricals. We have a lumbricals here, lumbrical muscle, and this is trochleus muscle. Okay. First thing, ask the patient active movement. Ask the patient to fist like this. Ask the patient to do fist, okay? By doing the fist, the patient is doing is using all the flexors. Using all the flexor of the MCBs, flexor, the B proximal interphalangeal and distal flexor, they use each flexor. All the flexor muscle you assess. If the patient have a weakness into the flexor muscle, he is unable to do a complete fist. You see that the hand like this. His hand is not completely, there is a weakness here, or there is weakness in the flexion. You see there is a flexion here, حتى the hand is open and able to completely like this. See finger here, and this one is open. There is a weakness of the flexor of the MCBs. Proximal and distal, the patient unable to close the fingers. You see his finger like this. In this position, this indicates there is a weakness of the flexor. Fist is very important. Okay, while patient, this is important part, the flexor. While he's doing flexion, ask the patient to test the wrist joint. Test the wrist joint by asking the patient to do an extension and a flexion. Extension, just a hand like this. Ask him to move his hand up, or ask him flexion to move hand down. Movement of the hand up, this extension of the wrist joint. Movement of the hand down, this indicates that there is a test for the flexion power. Okay. While the patient doing this movement, you are doing the passive part to assist the power. While he's doing the hand like this, ask him to flex. The patient flex, apply your hand here, and ask him to flex to see the power, to assist the power. Grade 2, grade 3, grade 4, grade 5. Put your hand beneath and ask him to flex the hand against the power, against resistance. Then while he's doing a flexion, patient, put your hand to the joint line here and ask him to extend the hand to assist the power of the extensor muscle. Clear? It's very important to do it for the wrist joint up and down. Okay. The other thing, to assist the power of the flexors, apply your finger within the hand. Ask the patient to put your fingers here, 2 fingers, apply it, and ask the patient to close the hand. If the flexor power is intact, the patient will close your hand tightly over your finger. If the patient has a weak muscle and are unable to do it, your finger inside, the patient will be unable to control your hand, meaning that he has a grade 2 or grade 3 power. Okay. Apply fingers, this for a flexor of the MCBs, proximal and interphalangeal. Okay. While in the fist position, you test for the wrist joint. Flexion, extension, abduction, and adduction and abduction. This is a 4 movement at the wrist joint. Flexion, extension, abduction, and adduction. This is important part to assess the power in these areas. Then you come to ask adductors and abductors. By examining the adductors and abductors of what's so-called lumbrical muscle, apply a paper in between the fingers. Apply paper in between the fingers here. Apply the paper in between the fingers of the patient. Use your hand, the same hand of the patient, and your same hand. If I need to assist the right hand of the patient, I should use my right hand. If I need to assist the muscles in between the index and the middle finger, I apply the paper here. I close my fingers, index and middle finger. The patient doing the same. His right hand, not the left hand. His right hand, my right hand. Same group muscle. We're comparing the same group of muscle. Muscle of the right hand, muscle of the between the index and the middle finger. So ask him to push the paper. Try to push the paper out from him. Paper is here and in the hand of the patient, and then try to move the paper. If the power is intact of the patient, you are unable to get out the paper from him. If his power is weak, so you are able easily to move the paper from him. Do it in sequence for every group of muscle. Apply it here, and then apply the paper here, then change the paper here, then change the paper here, and every time check the power. Right hand for the right hand of the patient. Now, this is a common mistake in the exam. Use his right hand for assessing the right and the left hand by using just one hand. Should the same group of muscle. So right hand for the right hand, left hand for the left hand. This is assessing the power of the issue of the lumbrical muscle by doing adduction and abduction. The other point in the examination for adductor and abductor, ask the patient to do what's so-called fanning. This abductor. Fanning, now يفتح يديه like this. This is using this test for the abductor. Ask the patient to open his fingers, doing what's so-called fanning. Opening the finger, and then you apply your hand apply your hand here, ask him to close, and then apply your hand to test the power. Ask him now to open his finger, okay? If the power is intact, the patient will be able to open his finger out. This abductor, they are good in power. If they have a weak abductor, patient unable. While applying your hand here, patient unable to open his hand. At the same time, ask the patient to adduct. Ask him to do fanning like this, and apply your hand here, 2 fingers, ask him to close. Apply your fingers here, ask him to close. Ask him to close to assist the adductor. By assisting of the abductors, assisting of the adductor muscle. Okay, clear? So we had to assist the flexors, extensors, adductor, and abductor muscle. Okay. Then come to lastly to the thumb. The thumb has a 5 movement. And the number 1, what's so called is adduction. Put the hand in the neutral position, like this. Neutral position. Ask him to do what's called this adduction. Bring the thumb toward the edge to the index finger. This is adduction. This is abduction. This is adduction. This is abduction. This is a flexion. Going to the palm. This is a flexion. Bring the finger out. This is an extension. The 5th movement was so called opposition. Opposition asks the patient to count the finger. يعد 1 2 3 4. Count the finger. This is opposition. This is carried out by the thumb. Called each opposition. Okay, very clear. And the 5 movements into the thumb: adduction, abduction, flexion, extension, and opposition by counting each finger. Every time you should assist the power. Patient do it actively, then you're assisting the power. While the patient doing adduction, apply your hand over the joint line here, and ask him to abduct, to assist the abductor. Apply your finger here, ask him to abduct. Okay. While he's doing abduction, apply your fingers here, ask him to, about the joint line, and the joint line, this is the joint line. Apply your finger here, ask him to adduct. While he's doing flexion, put your hand always over the joint line. Apply to the joint line, ask him to extend. Okay, while he's doing extension, apply your hand to the joint line here, ask him to flex. This is how to assist the power of the thumb fingers, okay. Then here we finish the movement assessment, go to the last part, neurological assessment. Neurological assessment, as we know, that the median nerve passing through the flexor reticulum, median nerve passing through here. So in most of the patients, like patient with rheumatoid arthritis, we have multiple causes of carpal tunnel syndrome, and a lot of causes: trauma, pregnancy, thyrotoxicosis. We have a lot of causes. One of them is rheumatoid arthritis. By excessive synoviitis, synovial hypertrophy, synovial hyperplasia, Banner's formation, all are accumulation of the tissue linked to the narrowing joint space and compressing of the median nerve. Okay. So compression of the median nerve leading to affecting of the median 3.5 fingers. So based on the median nerve involvement, the patient will have a paresthesia and numbness and pain. This is the 1, 2, 3.5. So this 1, 2, 3.5. All this area will be affected. Carpal tunnel syndrome, 3.5 finger will be affected. The thumb, second index, the middle, and part of the ring finger, half of the ring finger. All this area, patient will have complaining of pain, paresthesia, numbness, or a tingling sensation. Okay, clearly. So how to test for the median nerve involvement? We have 2 tests. Number 1 is Fallon sign. Fallon sign, then Tenner sign. Fallon sign asks the patient to force deflection. Put the hand like this and force the flexion each of the at the wrist joint. Force flexion of the joint like this. Ask him to put the hand, number 1, like this. Number 1, don't do it directly, it's 2 stages. Stage 1, put like this. Second stage, ask him to flex. While patient flexing, there is a carpal tunnel syndrome, which will feel sensation, paresthesia, numbness at the medial 3.5 finger. Sometimes patient doesn't feel paresthesia and numbness, but they have a pain at the forearm. Positivity of the test indicate 2 states. State 1, paresthesia, numbness, tingling sensation at the medial 3.5 fingers. Stage 2, patient may have no paresthesia and numbness, but he has a pain at the forearm, indicate positive test, indicate that the patient has a carpal tunnel syndrome. We are talk about the Fallon sign. Now going to about the Tenner sign. Tenner sign should percuss along the flexor reticulum at this area. Okay, this is the joint line. Just above the joint line, come from medial to lateral. Use 2 fingers. Use the index finger, the middle finger, and percuss over the flexor reticulum here. Percuss about this area, and ask the patient about sensation. The patient has paresthesia, numbness at the medial 3.5 finger, or pain at the forearm indicate that tunnel test positive, and this suggests that the patient has a carpal tunnel syndrome. Okay, by this brief introduction, we finish the rheumatoid hand examination. So go into that sequence, okay, and you feel that you have done all the point to fulfill the criteria for diagnosis of rheumatoid hand examination.